If I walk over to the House of Representatives, do I have to wear a mask?
Senator Kennedy.
Thank you, Madam Chair. Madam Director, thank you for being here today. I know how busy you are. I've been in my office listening to some of the testimony of both of you, and I'm a little uncertain about some of the answers, which is probably a shortcoming on my part. Madam Director, could you in 1 minute summarize for me what the recommendations are today from your agency about wearing masks?
Absolutely. First of all, can I just say thank you for your YouTube video for promoting vaccines, which I just adored.
Did you like my singing?
Yeah, I did. Thank you very much for doing it.
You're under oath now.
Yes, I did. Even so, I did.
Thank you for that.
Last Thursday, we released guidance that demonstrated for an individual who is fully vaccinated and not immunocompromised, that they are able to safely unmask, with the exceptions, certain exceptions, of course, in travel corridors, healthcare settings, that if you are an individual, you can safely unmask if you're fully vaccinated.
Inside and outside?
Inside and outside.
Okay. What role do the state regulations play with respect to that?
We are working now to update all areas of guidance, but here's what is really, I think, important to understand. We are not a homogeneous United States. We have counties that have less than 20% vaccination.
Yes, ma'am, but I don't want to get too off the question here. If I walk over to the House of Representatives, do I have to wear a mask?
Those are locally driven policies, but we felt that it was important for the science for us to convey the science of what is safe for individuals.
Well, I'm trying to understand the CDC recommendations, and I appreciate it. Based on the CDC recommendations, if I walk over to the House, are you recommending I wear a mask?
If you are by yourself walking over to the House and you're fully vaccinated?
No, ma'am, once I'm over there. I'm vaccinated. Once I'm over there and I'm talking to some of my colleagues.
We have really encouraged that the policies of mask wearing be locally driven, and the reason for that is because every community, every county has different rates of disease and different rates of vaccination, and that's really
What's different about the House? Do you know?
I don't know the rate of vaccination around the Capitol nor the rate of disease around the Capitol off the top of my head.
Okay. What about airplanes?
What is the policy on airplanes? The policy on airplanes is to wear a mask.
Okay. And why is it different on an airplane as opposed to a restaurant?
So the CDC provides guidance for what is safe to do. The federal policy is obviously an interagency policy that we need to look at across different agencies. What I will say, though, is that there's very little choice when you board an airplane as to who's going to be sitting next to you, who's around you. And also, airplanes may be a place where we have more variance because of the travel from international places.
Okay. Last question. What, in your opinion, was the origin of the virus?
This has been studied by the WHO.
No, ma'am, I'm asking your opinion.
I don't believe I've seen enough data, individual data, for me to be able to comment on that.
What are the possibilities?
Certainly the possibilities of that most coronaviruses that we know of are of origin from, that have infected the population, SARS-CoV-1, MERS, generally come from an animal origin.
Are there any other possibilities?
Certainly a lab-based origin is one possibility.
Okay. Is the United States funding gain-of-function research?
Not to my knowledge.
Okay. Can you get an answer to that for me and let us know, let the committee know?
Dr. Fauci would be the one who knows best, and he testified last
Dr.
week.
Fauci seems confused. I'm asking, with all due respect, I'm asking you to get us that information. Where throughout the world, including but not limited to the United States of America, are we doing research on these viruses to make them contagious in order to study them? That's what I mean by gain of function.
I understand. We certainly can have our staff look into this. I don't know that we have the access of labs across the world, just the ones that are funded here in the
Yeah,
United
but
States.
you're the head of CDC. I bet if I bet that you get your phone calls returned.
Okay.
Would you get us that information?
I'd be happy to give you the information to the best of my ability.
Okay. And I'm going to do a complete album of my singing. I'll send you a courtesy.
Will you sign up, please?
Sure. Thank you. Thank you both for being here. Thank you, Madam Chair.
Senator Baldwin.
Thank you, Madam Chair. I want to pursue a similar line of questioning that we just heard from Senator Kennedy with regard to masking guidance. And when I reflect from the period of time when the pandemic was first identified, the Department of Labor and the agency charged with occupational safety and health did not issue any sort of emergency temporary standard with regard to workplaces relating to this pandemic. And frankly, while there's been much work done on that in this new administration, we don't have one yet. And so I'm just delighted by the progress we're seeing. Generally, I see that light at the end of the tunnel getting brighter and brighter and brighter. And certainly the CDC's updated mask guidance for those who are vaccinated is a reflection of that progress. But I am concerned about the impact of this guidance on workers, and particularly those who work in crowded conditions, such as meatpacking facilities, where we have seen horrendous outbreaks in the past year. So, Dr. Walensky, I'm wondering when we can expect perhaps more detailed guidance for workplaces such as meatpacking plants and other crowded facilities where there's going to be a mix of vaccinated and unvaccinated workers, and how that's going to interact with the very recent CDC guidance on mask use for those who are vaccinated. What should workplaces be doing right now?
Thank you so much, Senator Baldwin. The meatpacking situation was really, really difficult. So many people affected and lives lost, and a real challenge for the nation to react to that. Updating guidance for workplaces, including the higher risk ones, is a high priority for us that we're actively working on. As you know, the initial individual guidance came out last week, but updating guidance for particular settings is critical. Our National Institute of Occupational Safety and Health is working closely with OSHA around getting the best science to the Department of Labor, who has regulatory authority, but we are at CDC updating our guidance for the particular settings in light of the newer science.
I appreciate that. I want to ask a question of you, Dr. Schuckett, about the importance of communication in public health. Early in the pandemic, again, we had to get out a lot of information on what COVID-19 is, how it's spread, what precautions people can take. And likewise, now we're in the vaccination phase and we have to communicate about its safety, efficacy, availability, et cetera. Last year, I wrote the CDC requesting that they provide information on the spread of COVID-19 in Hmong language. The CDC later updated their material, which was extremely helpful for Wisconsin's vibrant Hmong community. But we also need to make sure that we are doing exactly the same to make information on the COVID-19 vaccine accessible and available for all communities. So, Dr. Schuckett, how is the CDC using what it learned from sharing information about the spread of COVID-19 to communicate the importance of getting vaccinated to those who have limited English proficiency? And will the CDC be making information on the COVID-19 vaccine and how to get vaccinated available in more languages?
Yeah, thank you so much for that set of questions. I think that communication has never been more important nor more difficult than the past year, and reaching people with limited English proficiency has been really important. We have a toolkit available in 34 languages, and our vaccine information, including our vSafe, the little app that helps people follow side effects after getting vaccinated, is available in multiple languages. But it's not just what we say, it's how we say it and who says it. And so one of our strategies is working through trusted messengers and partners of the community, from the community, who work with groups day in and day out. And so part of our strategy is funding of jurisdictions for them to have community-based groups really get that message out in ways that are accessible. These are really important issues, as we know. Back to the meatpacking outbreaks, we had people speaking multiple languages in very close quarters at risk for spread, but also not necessarily knowing who they could trust in what they should do. So we clearly want to get the vaccine information to them. Another thing I would mention is the partnership that CDC and the administration has had with HRSA around the federally qualified health programs, because they have, the federally qualified health centers have a real concentration of patients served with limited English proficiency, and both through mobile clinics for vaccination and through community vaccination sites, they've been able to reach those groups.
And Senator, if I might add just real briefly, one of the things that would be really helpful for us is working with those industries to encourage employers to get their employees vaccinated, that time off, paid time off, to ensure that they, when they return to work, they are vaccinated.
Thank you, Senator. Senator Braun.
Thank you, Madam Chair. Dr. Walensky, I'm glad that the recent ruling was made that if you're vaccinated, you don't need to wear a mask. I think it was getting very confusing for not only getting more people vaccinated, because they were saying, well, why should I get vaccinated if I still have to wear a mask? So thank you for that. But I do have a question. I know that on March 29th, the president was criticizing some governors about removing mask mandates, and of course that now has changed, and I think the reason is what I've just said. But what about, since the science now and the guidance is clear, what about local mayors and governors that aren't following the science, when that has kind of been ballyhooed as the thing to do? I believed in that from the get-go as well. Especially when the tools were very uncertain, the distancing and all that stuff made sense. I thought you were silly not to abide by it. What about now for the places that are, I think there's a liberation feeling out there, and thank goodness for the warp speed and getting the vaccines in the arms. Is this unnecessary for governors and mayors across the country to still keep a mask mandate in place?
Thank you for that question, Senator. We released guidance on Thursday that said for individuals, if you are vaccinated, fully vaccinated, you can take off your mask with several exceptions. One of the things I think that's really key in this is to recognize that we're not a homogeneous country, that there are some areas, that some counties that still have less than 20% of people vaccinated. There are some counties that still have greater than 100 per 100,000 cases in a 7-day period of time. And so I actually think, as I look at the map, a very heterogeneous map of how we're doing with cases, how we're doing with vaccinations. The decisions about whether to take off a mask mandate have to be made at the local level, have to be made at the community level. There are still some communities who are suffering. We know African Americans lost 2.9 years of life compared to white Americans losing 0.8 years of life. We need to make sure that, and they are probably the communities that got access to vaccines last. We're working on that. We've had extraordinary improvements in our access to, in our racial and ethnic minorities having access to vaccines. vaccines. But I do think that these need to be made at the local and community level for exactly that reason.
Do you think it'll be confusing, though, even for those places that have lagged in getting their citizens vaccinated, to see that there's not that incentive in place, even in the places that have been slower to do it, that would be an encouragement if they see people without a mask and they say, well, they're vaccinated, I want to get one?
I think it would be really amazing if our new guidance got more people vaccinated and was an incentive for more people to get vaccinated. But I don't make CDC guidance. My whole agency does not make CDC guidance based on what it will help people do. We have to do it based on the disease that's out there, the access to vaccines, and based on the science that has emerged. I really am hopeful that that will help and to incentivize people to get vaccinated, but that wasn't the reason for our guidance.
Okay, another subject. Since we're kind of at least ebbing into a situation that looks like here in the U.S., other countries, some places it's still running rampant like India, when do we turn the focus? And I think we've been lucky that vaccinations have come this quickly, but therapeutics would seem to be that final defense for anyone that did not have a vaccination available. And now for the few cases that could still slip through the cracks, to where it's impacted with so much data, such a small portion of the population, disproportionately and horrifically, elderly, predisposed with other conditions. When do we start turning our attention to helping them once they get it? Because we're going to still have cases, depending on variants, how strong they are, to where the emphasis goes to therapeutics and not vaccinations, especially for places where the vaccine is generally working, but you still want to have tools to help those that get it.
Absolutely, and I know. First of all, I think we're working now. We have said if anyone is not safe, then no one is safe. We really do need to make sure that we have resources to other places. If variants emerge, they will come to our shores. So we have to be able to do that. I also know that NIH has invested in making sure that we have therapeutics. One of the first things that we had when I was rounding on the wards last May was remdesivir, and that was the first sign of an antiviral. We don't have anything really that we can give quickly over the by prescription to outpatients. Right now, we're relying on monoclonal antibodies. They're hard, they're clumsy, they take a lot of resources, they're expensive, and so I do believe that we need, in this next phase, after we get the majority of Americans vaccinated, we do need to turn to antivirals that are able to be easily administered in an outpatient setting.
And final comment, I think that's going to be important because we don't know how much variance will become an issue. And at some point, when we've generally tamped it down, I think it's incumbent on us to put focus on how to help those that end up getting it, especially that are so predisposed with bad outcomes. Thank you.
Thank you.
Thank you. Senator Manchin.
Okay. Thank you, Madam Chairman. Appreciate it very much. And I want to thank all of you for being here. Dr. Shukut, first of all, thank you for your service, many, many years of service. And I appreciate very much what you have done. And my first question will go to you because you probably have the historical knowledge of how we got to where we are. Over the last decade, the United States has lost over 50,000 public health jobs. And during that time, we have faced the H1N1 flu outbreak, Ebola, Zika, and now COVID. Within the last 5 years alone, West Virginia has lost nearly 30% of our public health workforce. One thing we know from this pandemic is that we were not prepared. While we have been able to hire temporary public health workers in the last years, these positions, they're not permanent and are at risk of disappearing after the public health emergency is over. So can you speak to how we became so vulnerable and fell behind the curve in our ability to respond to this pandemic? And how can we keep it from not happening again? I know you all touched on it, but I just can't believe we were this unprepared.
Yeah, I think the state of our preparedness was a real tragedy, and part of that relates to the public health infrastructure. Over and over, we invest in response to a crisis, but in ways that haven't provided sustainable capacity at that front line where the problems happen.
Was these decisions made higher up within whoever the administration may have been, whether it's Republican or Democrat? Was it made at that level, or was it made at the head of the CDC?
The biggest funding increases we've gotten have been emergency funds from Congress that, you know, happily supported response for H1N1 and Ebola and Zika and COVID. But the dollars that were there day in and day out to provide reliable jobs for that local public health workforce were not there. And whether it was state budgets or federal budgets, that, you know, you cited the statistics of the job loss. Beyond that, the jobs aren't the same anymore. You know, we talked about the data. Our data systems have really not kept up with the times. We have a very fragmented data systems that
Let me
have
ask
not
that
been
maybe-
modernized.
My time is limited. I want to ask Dr. Walensky's question, but on this, Dr. Shukat, what type of a time basis would you say that we should be looking at for funding? I mean, to have confidence in the funding, permanent funding over a, what, 5-year, 10-year period? So it's consistent, you know what you can do and be prepared?
You know, I think the approach that was taken for NIH to strengthen their capacity for vital biomedical research is what needs to happen for the vital public health infrastructure in the country, where it's not a feast and famine, but that local,
Okay.
state, and federals can plan.
Well, now would be the time to do it. If we're ever going to do it, we should do it now, since it's all very, very fresh in what we've been able to endure. Dr. Walensky, as you're aware, we're facing an epidemic with pandemic. West Virginia is ground zero for the drug epidemic, with the highest rate of drug overdose deaths in the country. To make matters worse, 2020 was the worst year yet, with over 90,000 deaths. We saw at least 47% increase in the state of West Virginia with overdose deaths. So what resources is CDC providing to states to combat the epidemic?
Thank you, Senator, for that question.
And also, here, a second part of that would be working on helping, what CDCs are working on helping increasing testing for viral hepatitis and HIV. We've had a tremendous, horrendous situation with that.
I can tell you, just before coming here, I spoke to one of my infectious disease colleagues in West Virginia, and she was telling me that they have opened neonatal detox units. I understand.
Unbelievable.
It's unbelievable. It's unbelievable. And so we know that we need to tackle this. We need to encounter this. We need accurate data. We need interventions that can, and we need resources to be able to invest in opioid naloxone programs that are reaching the community health workers that can do the outreach to talk to people and intervene at the local level where these are happening. We need toolkits. We need information and mental health support services to intervene.
My time's running out. I want to ask you one other thing. We produce very little of the things that we basically need for medicine. Penicillin, do you think penicillin should be produced in America? Do you think doxycycline should be produced, an antibiotic in America? And if so, what should we do in order to do that, or stockpile strategically for our own protection?
I think we need to have a public health infrastructure and a pipeline that allows us to respond to pandemics and to epidemics and to infectious threats.
Do we have any manufacturers that are producing these in America?
There are limited manufacturers producing penicillin, that I can tell you, because in fact, we've had penicillin shortages. Penicillin has gotten extraordinarily expensive, and in fact, some colleagues of mine have once said it should be cheaper than the tubing it runs through, and in fact, it's not.
Should the CDC basically, I mean, your recommendation would be for production, we should be producing these in America. We need to have something from a professional like yourself to get back to producing things in America, not depending on foreign supply chains.
So one of the things I can just mention for penicillin specifically is it's particularly hard, given the allergies related to penicillin. It's actually particularly hard to do. There are limited plants that make penicillin, but your point is well taken.
Thank you. Thank you, Madam Chairman.